Please join me in welcoming to the Distinctive Voices podium, Dr. Christy Anseth.
Well, thank you for the introduction and thank you for the kind reception. And I'd like to tell you a little bit about some of our research interests and a little bit about this field that's sometimes called tissue engineering or regenerative medicine. And I kind of gave the secondary title of the body shop because I think we can all in our own minds think of different injuries or diseases or many times where you'd really wish you had a new, and you fill in the blank there. But the perspective that I'd like to walk you through today is give a little bit of how the field sort of nucleated some of a historical perspective. What have been some of the advances? I've been working in this field for close to 2 decades, and how far have we come? But also, what are some of the challenges and the directions that we need to tackle before this idea or concept becomes more mainstream or integrated into clinical science? So let's walk through just brief history. We'll take you back 3,000 years or so. We didn't understand many things. We didn't understand how infections occurred. So people would be bled. Or in injuries, many times there were amputations. They're worried about saving life and not necessarily about the function for the person. But even 3,000 years ago, if you look on this mummy, and if you look really closely, their big toe here, they had lost their big toe, and this is a wooden toe. So even then, they could understand and try to design replacement body parts because your big toe is very important for balance and helping in ambulation. All right, so now let's fast forward and let's look kind of at the current century and what's happened in medical devices. We have all kinds of replacement body parts that help with sustain our lives, improve our quality of lives. We have total knee replacements and hip replacements when we have arthritic joints. We have synthetic heart valves that can be used to replace if you have a diseased valve. We have pacemakers. We have vascular grafts. There are all kinds of medical devices literally saving people's lives. But one aspect about this, so while these have had quite a great deal of impact, and we'll talk a little bit about both of these in the talk today, they don't necessarily look a lot like our tissues. And so that's what this field is about, this tissue engineering field, is how can we get the body to heal itself when processes go awry? Or how can we coax the body to regrow when it's not naturally occurring? And that's really what this field is about. So let me give you one other little motivation here. So this was a little note I read in the Journal of the American Medical Association. And it was written, this article, it was written right at the turn, we were going from 1999 to 2000, and they're talking about the babies that were being born in this century, what would their lives be like? And so one of the things you'll notice, they talk about the millennial child. It's being admitted into the hospital, and it's November 17th, 2150. So they're already talking about people living 150 years, and the article is really entertaining, but I'll blow up just this one area here. So this child, who's now a grown adult, has had many different surgical procedures. And if I blow up this one, she's a 150-year-old female. She's had a history of heart disease, cataracts, leukemia, and she had a bone marrow transplant 75 years ago to treat that. She's had her diabetes and renal failure. But here's one I like. The patient's past surgical history includes coronary bypass grafting 80 years ago, followed up with gene therapy. 40 years later, bilateral corneal transplant, 75 years ago. Bilateral knee replacements 47 years ago, and a femoral head excision with regrowth by osteophyte stimulating factor for osteoarthritis of the left hip 35 years ago. So literally they were removing part of her hip joint and regrowing it. So this is obviously very speculative, and it's meant to be very thought-provoking, but it raises the question, what do we know, and what might we be able to do in the next decade? Or if not in my lifetime, maybe my daughter's lifetime. Sorry, wrong answer there. So what are some basics? Well, some basics are that all of us, our bodies are continually regrowing and remodeling and replacing our tissues. Our skin is regenerated constantly. Our blood is regenerated. You break a bone and bones will heal. So there's this constant turnover. So our body does know how to grow many tissues, and it does it very efficiently and typically in a way that it lasts our whole life. We also know from biologists who can now take cells out of our body and grow them in dishes in the laboratory. And surprisingly, we've only been able to do that for about 50 years now. But when you grow those cells, when they're taken out of the body, many of them will spontaneously form different structures. So if I take your heart cells out, the cardiac myocytes, and culture them in a dish, they will start to spontaneously beat. And if you give them adrenaline, they'll beat faster. The tricky part is getting them to beat in a coordinated way. So you could start to think about trying to use those cells to repair somebody's heart muscle after they've had a heart attack. So a key, though, is our bodies aren't just a factory of cells, but those cells reside in an environment of our tissues. And those are really important, and cells get lots of information from that tissue or that material environment, and it really plays a key role in how those cells divide and grow. If they're a stem cell in your body, how it will respond to a wound and differentiate to the right tissue type cell. And it also gets lots of function. So this is sort of what this field is about. How can we learn to coax those cells from our body by designing different types of material environments to get them to grow functional types of tissues that can be used as replacement parts and integrate with our body. But rather than being a synthetic replacement part, a real, living, viable tissue. So one of these concepts, one of the very early concepts, was aimed at trying to regrow and regenerate skin for patients that maybe had large burns over fractions of their body, or maybe they had a diabetic ulcer that was very difficult to heal. And so early on, the material environments that people chose, they would take degradable sutures and they'd weave them together into a fabric, almost like a piece of felt. So that was going to be the temporary scaffold or structure. And then they'd put the patient's skin cells on these, and the cells in your skin actually can grow very fast, regenerate football fields of skin. And they would seed these on these degradable sutures. And then those degradable sutures, they just break down with time like they do in our body. And the cells on them, surprisingly, here's the cells here, a picture of them, they're starting to grow in number and they're starting to fill in these blank spaces, and they will go on and regenerate something that looks very equivalent to aspects of our skin. It's not going to have hair follicles or pigment, but functionally it has many of the same features as skin, as a protective barrier. So how do we go beyond something like this? And you start to think of more complex tissues and structures. And so it really involves bringing together and understanding the cells and their biology of the cells, integrating new types of materials, the scaffold structure, and then collaborations with those that apply it in medicine, so you can understand how to integrate these and solve problems that are important. Now, myself, I have interest sort of in this area, and I collaborate a lot with people in these two communities. And one of the things about this area is that many biomaterials, things used in medicine, were never really designed to come into contact with the human body. Oftentimes, they became defined as a biomaterial because there was a trial and error process or a serendipitous event that a material was implanted in the body, and then they'd watch and see, is there not so much inflammation or is there lots of inflammation? And that would define what many of the biomaterials were. And so this is a slide that I like from a former mentor of mine, Bob Langer, that shows this whole history of all the different devices we've had: artificial hearts, vascular grafts, breast implants, bone cements to glue in all those orthopedic devices, replacements for your jaw joint. And this is the names of the polymers that were used, but these were their initial uses. Many of them are from clothing, you'll notice. And again, while they could be functional, it has led to bottlenecks in some of our progress. So to this date, one of the problems we have is whenever you put a material in contact with blood, you'll get clots on it many times. And that's a really big problem we've had to try to solve. So one might not expect something that's designed to be more of a sock material may not be so good as a vascular graft material. So the idea then is, how can we rationally design different types of scaffolds, design them to come into contact with cells, design them to integrate with our body? And so then the types of things you would think in your engineering design principles is, well, of course it needs to be biocompatible. Many times we want it to be degradable so that that part goes away as the cells rebuild and make the natural tissue structure. You have to think about having the right physical and mechanical properties. You don't want to put something that has the properties of a tough bone into somebody's heart valve. So you think about mechanics of those materials. You have to be able to put cells in them, and our bodies are three-dimensional. So that also means being able to fabricate and make materials in 3 dimensions with cells. And then providing instructions to those cells. And so that's where chemistry comes into play, because cells communicate with one another by secreting molecules, proteins or growth factors, hormones. And that's how cells get that information. And so you have to figure out how much information do you need to give those cells inside of those material environments. So today I'm going to tell you and teach you about one particular material. There are lots that one can choose from, but we work a lot with these hydrogel materials. So here's a macroscopic picture of a hydrogel. Some of you may have made hydrogels before, so Jell-O is a hydrogel. Some of you might be wearing a hydrogel. Contact lenses are hydrogels. So what hydrogels are is, if you could see the molecules inside of here, so if I used an electron microscope, what you would see would be really long chains. Like, think spaghetti noodles. And those spaghetti noodles, those chains would normally dissolve in water, but they're all tied up with one another and interacting. And so that creates a 3-dimensional mesh or network. And that causes the material, it can't dissolve anymore, but it just imbibes large amounts of water. So it swells up in water. And that is a really good model for many of the soft tissues in our body, because our bodies have large amounts of water. Cells can live inside of these systems. I'm showing you here, we use a fluorescent microscope, and we can watch. These happen to be some nerve precursor cells that are inside of this hydrogel. And now the engineering and the challenging part comes in is, how do you figure out what signals to give those cells at the right time and in the right place and with the right context and with the right dose so that I can direct those cells. And sometimes the question becomes, how simple will be complex enough? Maybe I don't need to recapitulate everything the body does when it's growing and developing or when a wound is healing, but maybe I could just intervene just enough so that the natural course would occur and make a simplified system. All right, so I'm going to give you 3 examples today, and they're going to be examples of increasing complexity. So the first example is one with trying to regenerate cartilage tissue. And in this example, it's the simplest example where the cells really just need to touch and feel the scaffold. They're going to get physical cues from that, but I don't really have to do much else, and I'll explain why. And then we're going to talk about trying to regenerate a heart valve. This gets more complex. And here, the cells need to be able to talk to the scaffold. So they need to feel and touch it, but they also have to talk and get information, exchange back and forth. Then we'll talk a little bit about neurons and trying to treat neurological diseases. And this is where it gets even more complex. The cells need to feel, touch, communicate, and talk with that scaffold, but it's no longer a single sentence, but it's a whole paragraph. You have to have a complex series of exchange of information. All right, so let's start with cartilage. So cartilage is on all of our articulating joints in our body. It allows you to move those joints, cushions when you're bearing load on them. It also provides this low friction surface. But the unfortunate thing about cartilage, so here's your knee joint, here's your kneecap, and here's the articular cartilage surface on it. But cartilage is a tissue that has a really limited capacity to heal itself. It doesn't have a blood supply, doesn't have a nerve supply. And when you damage your cartilage, and so in Colorado we like to ski a lot, and if you hit one of the bumps too hard, you can crack some of your cartilage and damage it. And then what happens is that you disrupt the biomechanics of this nice surface. And it can take a while, but over years or decades, that cartilage will start to wear through. And it will wear away down into the bone. And once it's worn away and you have bone on bone, that's when it becomes painful to walk. All right, so I'm going to show you a picture of one of these cartilage defects. It's an open surgery, so if you don't want to see it, just look down if you're a little queasy, and I'll tell you when the slide is away. All right, so here is healthy cartilage, and there's a huge cartilage defect going all the way down to the bone. That's the kneecap. Okay, all right, so I took that away. So that was a 41-year-old woman. Debilitating knee pain. So the best option for her is the surgeon would normally recommend a total knee replacement. Now, I don't know if there are any orthopedic surgeons in the audience, but hopefully I won't offend any of them, but they're very skilled carpenters to me. They use oscillating saws and blades and burrs, and in a total knee replacement, they'll take away the ends of your bone, your lower leg bone, your tibia, and your femur up here. They're making space for this new implant. And then they'll put this implant in place, and they'll kind of contour it to the bone, and they'll use different instruments to hammer this on, and sometimes they'll glue it on as well, shaping it and contouring it to the bone. And this is your new total knee replacement. Works tremendously well, relieves pain, patients recover reasonably quickly. But if you're 41 years old, this will not last your whole life. So you're looking at having multiple knee replacements. And if you're 41 years old, you also have limited activity. You may not be able to play soccer and other types of more robust activity with this knee joint. So this patient did not want to have a total knee replacement. So state of the art at the time was a cell-based therapy, where they take a biopsy of the patient's own cartilage. So we all have lots of extra cartilage in our body. The cells are healthy. So if you take cartilage from a non-weight-bearing region and you digest away that tissue around it, you can get the cells from that patient. And then I can grow them up in a bioreactor, your own cells, and expand them to get a large enough number of cells to try to treat that big defect. So I'm going to show you one more open surgery. So again, if you don't want to see this, you can look down. So here's what happens. They grow up the patient's chondrocytes, the cells in her cartilage tissue. They take a piece of tissue from down here on your bone called the periosteum, and they suture that in place, and the cells are put underneath here with the hopes that those cells will regenerate and regrow a cartilage matrix. Okay, so that slides away. Now, the problem with this approach is not that those cells can't make tissue. So if I take them from one place and I put them where they need the tissue, they can rebuild and regrow cartilage. But when that defect is really large, it's very hard to do that just using cells. Works okay for small defects, but most patients, when they come to their orthopedic surgeon with lots of pain, they have a large defect that needs to be treated. So we got interested in thinking about, could you design different types of hydrogel systems that could be used as a carrier for these cells and provide a three-dimensional framework? And so when you look at cartilage tissue, and if you were to take a thin section of it and stain that tissue and look at it under a microscope, what you would see, so these are the cartilage cells, they're called chondrocytes, and those chondrocytes just kind of sit embedded in this tissue around it. So they're making this tissue all the time. And one of the parts of the tissue they make are this collagen. So I'm showing you here a stain of blue. That's looking at the collagen molecule. Those are the struts and the shock absorbers and the scaffolding. And then the other molecule that they make are these proteoglycan molecules that are stained red down here. And these are really highly branched, charged macromolecules. And this causes the tissue to imbibe large amounts of water, and it imparts lots of very unique mechanical properties to the tissue because of that. So it has a large amount of water. There's only one cell type that you need, and everybody has lots of that extra cell types in their bodies. So the idea is, can I design a delivery system so that when you have damaged cartilage here, so the problem is that the cartilage over here can't communicate with that. Remember, there's no blood supply or nerve supply, so they have no idea it's damaged there. But if I put healthy cells here, and if I make a gel inside the tissue, then maybe if I embed cells in this three-dimensional environment and I get the right mechanics and physical properties, over time will those cells regrow and regenerate something that looks like healthy articular cartilage? So the things that you can think about in designing some of these hydrogels is what I'm worried about. Remember, it's a three-dimensional mesh or net. And the bigger that mesh is, the more water it takes in, but it's also a weaker material. So when I apply a load, it will deform more. And then the tighter I make that mesh, the less water it imbibes, but it also gets stiffer. And so you're kind of trading off those different types of properties with how I make this mesh. And this is the water content here. So as the mesh gets smaller, the water goes down. And as the mesh gets smaller, the stiffness goes up. And so you kind of are optimizing those for these chondrocyte cells. So we grow these chondrocyte cells in these different types of matrices, and then we want this material to fall apart with time. So we can get this about right, about what cartilage tissue would have. and then we watch what the cells do. So these are healthy cells, and remember they make that collagen, and they can make that proteoglycan molecule. I'm just going to show you the collagen. So these are those cells right here, and this is the hydrogel, and the cells are starting to make the collagen. But these look very different, don't they? So who wants this piece of cartilage? Any takers? Anyone want that one? No hands up. And so the point here is that you have to tune how the material degrades and breaks down. And you have to match it to the rate at which the cells make the tissue. So over here, the gel is degrading too slowly and it's impeding the formation of the tissue. Here it degraded too quickly and the cells hadn't made enough, so I regenerated cartilage that has a defect in it. Over here, we can optimize that. So that took a PhD student's thesis in several years. I'm only telling you part of the story. But it's possible to regrow and regenerate cartilage tissue in the lab. So then we tried with collaborators from Johns Hopkins University trying to treat a goat's knee joint. So we created a defect cartilage here. And then we came back several weeks later and saw large amounts of tissue that's regenerated. And if you don't treat it, you don't get much healing at all. Remember, cartilage can't heal itself very well. And if you look at it, if you section that cartilage, here's sort of what your native cartilage looks like when it's not damaged. So here's the bone, and here's going all the way to the surface. Regenerated cartilage surprisingly recapitulates many aspects of that. They're not perfect, but it looks pretty good. And it has lots of the properties of what native cartilage is. But there's still challenges. So here's a tissue that, an advancement where there's an obvious cell source. There's only one cell, so I don't have to worry about trying to grow in blood vessels and innervate it. And those are healthy cells, and they can regenerate and regrow tissue. We still try to make our articular cartilage, it's always just a little bit weaker than that of your own articular cartilage. So we're trying to still solve some of that. And another tricky part, too, is sometimes at the interfaces, how the engineered cartilage interfaces with the healthy cartilage. But again, this is something that is in our lifetime. You can go to a doctor and have procedures that are cell-based to try to regenerate and regrow cartilage. So this is available today. Let's look at the second example with heart valve tissue engineering. So in your heart valves, your heart valves are pretty amazing tissue structures. So this is a picture of your aortic valve. So your heart has 4 valves, and they open and close, maybe 60 times a minute, 80 times a minute, depending on how your heart's beating. They direct flow through the chambers of your heart. From an engineering perspective, it's this perfect, amazing one-way valve that for many of us, it lasts our entire lifetime. But the valves are this incredibly delicate tissue. So this is an aortic valve, and these little leaflets here, there's 3 of them. They're very, very thin, like 200-300 microns thickness. And there's a huge pressure drop across here. And so the cells inside of this little leaflet, and they're called valvular interstitial cells. I'm just going to call them VICs. They're constantly repairing, regrowing, regenerating this tissue structure. And the tissues now, so they have the collagen and the proteoglycans like the collagen did, but it also has this molecule elastin. And the elastin helps it when it's opening up to snap back closed. And it's really important how these are organized to the function of these valves. Now, the problem, with our valves is that these cells are actively and they're constantly turning over and making the tissue, but sometimes something goes wrong. And when there's an injury and they get activated, they stay activated. And they start making all this tissue and they make too much. And it becomes fibrotic and really thick. So here's a fibrotic leaflet. And all of a sudden, your valves don't open and close properly anymore. And this means, with continued disease progression, that you have to have a replacement. And so there are several hundred substitute valves placed every year worldwide. In fact, Edward Life Sciences locally makes many of these valve replacements. And you can have choices of mechanical valves. Mechanical valves are synthetic materials that are very reliable and durable, but we have that blood clotting. So if you have a mechanical valve, it could last your whole life, but you would likely have to be on anticoagulants to stop that from happening. So then the other option is they'll take valves, either from human donors or pig donors, but they have to take all the cells out of it because those cells are not from you, and so it would cause an immune response. So they just leave the material behind now. They take away the cells, the living part, and you're left with this tissue matrix. And this looks a lot like your valve. This one doesn't look so much like a valve. It's a nice engineering one-way valve. This looks more physiologically relevant. It's a pig's valve. But the problem here is that those valves usually don't last your whole life. So problems can occur. It's not living anymore, right? And so the tissue can wear down. Sometimes it can calcify. And so there's interest and need of, well, what if I could regrow a living heart valve? This could potentially then last the patient's whole life, and maybe especially be very impactful for babies that are born with heart valve defects. Because babies born with heart valve defects, there's no good solution for them because they're growing so rapidly. So they face multiple surgeries of having multiple replacements. So how do we get this to work? So I don't know if I can switch over to my computer. I'm not going to go on slideshow, but I just want to show a couple of movies here. Can I switch over to the laptop or not? So these heart valve cells, if you just put these inside of the same hydrogels that the chondrocytes would be in, and so I'm showing you them here, they are round up like the chondrocytes were, and they try to move around, but they can't. They can't find anything that they recognize to guide them to grow and move. So you have to think of new different types of chemistries. And in this video over here, what happens is that the cells can degrade the matrix, they can spread, and they move all around. So we'll upload some of these videos afterwards if some of you would like to see them. So the key component here was we had to think about what signals do we give these cells. And what we learned from was by collaborating with biologists is that when your heart valves are forming, there's a really important molecule called hyaluronic acid that's secreted by the cardiac jelly in your heart, and that causes the valve cells to grow into this and make your valve. So if you put in this molecule, this hyaluronin, and we can control the dose of it and the size of it, what happens is these valve cells will begin to spread and to move through this, and they're locally degrading this matrix. So the cells are giving information to the scaffold saying degrade away, but now the scaffold gives something back. Because that hyaluronin, so I'm an engineer, I have to show at least one graph here, is when that hyaluronin degrades and gets cleaved up, the cell has a receptor for that molecule, and when it gets inside the cell, it causes them to increase in their number, and it also influences them to make more tissue. So the more it degrades, the more tissue it makes. So let's just see that visually. So if you watch these cells with time, they'll increase and grow in number. And not only do they grow in number, but they go on to make a very rich tissue structure. And here I'm showing you the structure of that elastin that's really important are these valve cells. And the elastin, this is a native heart valve tissue, and this is what we engineer here. So we get lots of elastin, but does anybody see anything different about these two? What you might like to change about our engineered? Yeah, I heard a few different, but that the elastin is not very organized or oriented in this. And so part of this is that it's really important when you're engineering and regenerating heart valve tissues to dynamically stimulate those, to put them in a bioreactor where you have flow and it opens and closes. And that's where some of the direction of the field is going, to create and regenerate and regrow different types of functional heart valve tissues. The challenge here, though, is figuring out the right cells to use, because you don't always have time to wait. If somebody has heart valve disease, you have a chance to regenerate and regrow inside of a bioreactor. But if it's an infant or a child born with a heart valve defect, you may need to do surgery right away. So there are different challenges to some of these different tissues that you try to regenerate. But here's one that we're making lots of advances in. But there are no tissue-engineered valves used to date in clinics. So let's talk about the last one here, treating neurological diseases and injuries. Spent a lot of attention and focus with the Brain Initiative, where neuroscientists are beginning to define and catalog every single nerve, or every single cell, not just nerves, inside of our brain, and their connectivity and structures. Here, the brain, we know many of the functional domains and regions in the brain, but now we're beginning to understand the cellularity. Even somebody not trained in this field, you can see dramatic differences in brain structure when you compare a normal adult brain with, this was a patient that had Alzheimer's disease. So you can see, like, for example, the hippocampus here, large degrees of loss of cellularity. So what are we going to learn from the Brain Initiative, and what might this mean for being able to treat different diseases of the CNS? And so one area that has been some growing interest in is trying to use cell therapies to treat Parkinson's disease. So Parkinson's disease, we know that there's a large-scale loss of dopaminergic neurons in a certain region of your brain, substantia nigra. Dopamine is responsible for our coordinated movements of our muscles and in our bodies. And many times by the time you have significant symptoms of Parkinson's, you've lost more than 90% of your dopaminergic neurons. So there are advancements in being able to take different types of stem cell populations and differentiate them to dopaminergic neurons. And there have been clinical trials taking those dopaminergic neurons and injecting them into patients' brains with the hopes that those cells could secrete and make dopamine and reduce some of the negative symptoms for those patients. Because it's very difficult with some of the drug strategies to treat Parkinson's disease. It's very difficult to cross the blood-brain barrier. But one of the problems with these cell-based therapies is, one, getting enough dopaminergic neurons and a reliable source of them. But two, if you just inject the dopaminergic neurons, sometimes they're going into an environment where they have a hard time surviving. So in many clinical trials, fewer than 10% of the transplanted cells would survive 1 week post-transplantation. So there's an interest in trying to think of strategies. How do we improve survival, especially long-term? Because 1 week, if you've lost 90% of them, 1 year, sometimes there's no evidence of those. Other times there's a very small population surviving. So perhaps one strategy would be to increase that survival. And so how could you design different types of gel carriers that could improve survival, could improve connectivity of those neurons with the surrounding tissue, and maybe that would help with long-term survival. But this is something that's tricky, and we have a lot to learn. All right, so we can watch these cells, putting them on top of a microscope, and in real time watch these different types of neuroprecursor cells and watch them survive and begin to extend little axons here. But they'll only do this if you give them multiple types of growth factors or cues. And we have a lot to learn about how to direct these axons outgrowing. How do we give the right survival signals? And so this is kind of the status of the field, is designing systems so we can figure out how many sets of cues do we have to give these cells so that they'll form. So here, this is after just 2 weeks. Look at this dense plexus of axons that are extending from this. And then what you care about is maybe how these are going to connect with different surrounding tissue structures. And then we can watch, and we're beginning to learn how neurons will communicate with one another. So this was a little video where we could load these up with different dyes that are sensitive to calcium inside of the neurons, and that's important with how they fire and communicate with one another. And so we can watch in real time how these cells communicate with one another, but we're really at baby steps of how we get neurons to connect and grow. Imagine even just the tiniest nick in your spinal cord, and we have a hard time reconnecting that. So there are big challenges in this field, but I think lots of excitement because we're going to learn a lot in the upcoming years. So as a few concluding comments, why do I think this field is important? Our body is this amazing engineered biological specimen with 100 trillion cells that normally we grow from babies to full adults. Our bones heal themselves. Our skin is cut and it will heal itself. We regenerate our blood. Our liver can regenerate. There's so many ways that it's this perfectly engineered system. And so tissue engineering in this field is really trying to focus on ways to intervene when these processes from disease or injury or something has gone wrong. Can we intervene just enough to reset the system so that it will heal? So I think there's great potential to improve quality of life. We're seeing increasing numbers of applications of cells being used as therapy in medicine. So I think that's going to continue to grow. We already have products of tissue-engineered skin. We have products that help our bones heal faster, ways to regenerate cartilage, and there are even examples of blood vessels that can be used that have been tissue-engineered in different bypass surgeries. But engineering more complex tissues and functional organs it's a really ambitious goal, and it's something that we're still pursuing vigorously, but you'll notice that a lot of these are tissues that have a structural function. It becomes harder to regenerate and regrow things like a small equivalent of a kidney, perhaps, or a liver, or even a heart muscle. So maybe some of you have seen in the press, especially over the last 5 to 10 years, and even different examples. So this will give some idea of some of the challenges of the field. Examples of sort of tissue-engineered products being used to treat people that have devastating conditions. So there was a human trachea that was used to treat a 30-year-old patient who had a failing airway because of severe tuberculosis. And they were going to have to remove her whole part of her left part of her lung. So a team, so this was a European team, they took a trachea from a donor, and they decellularized that trachea. And then they took bone marrow stem cells from the patient, And they put those cells, once they were coaxed to form the cartilage, or the chondrocytes that are found in the trachea, and then they had to culture it in a bioreactor. So it saved this woman's lung. After she was followed for 5 years, and she still has fairly good lung function. But now, this is treating one patient. It took a team of 3 people from 3 different countries coming together to tackle and solve this. And there are a few other examples of this being used, but it's not as widespread. But this is what's going to happen first before we develop the technology and are able to solve even more challenging problems. There's another team, Tony Atala's team at Wake Forest, where they tissue engineered a bladder. And they treated 7 young patients that were born with limited bladder function, and it was causing stress on their kidneys. So they tissue engineered a bladder from the patient's own cells, and this is kind of a layered structure, and the bladder was able to hold more pressure and maintain function and reduce some of that pressure on the kidneys. But one of the challenges is that the bladder wasn't innervated, so the patients cannot control and release their own urine. They still have to use a catheter. But still, it's an amazing advancement of a complex structure like a bladder. And then finally, very recently, some of the first human trials to treat macular degeneration based on induced pluripotent stem cells, kind of coming from a team at Japan, where they've learned how to take the patient's own fibroblasts, or skin cells, and then they reprogram them to a pluripotent stem cell. And then once they're reprogrammed, they can differentiate them into different cell types. And here, they're differentiating them into these retinal pigment epithelium cells. And that's one of the cell types that's damaged when you have a certain type of macular degeneration. And so they're going to treat 6 patients. Challenge here, $200,000 per eye, and it's going to take 10 people 1 year to complete this trial. Again, initial steps, big challenges, but I think that we'll be able to solve this and that some of these issues will be addressed with time. And some of these challenges, can be finding the right cell source and getting them in clinically relevant numbers. Defining and achieving the functional properties of a tissue equivalent. What do I mean by that? Well, maybe we don't really need to tissue engineer a whole pancreas, but maybe we could regenerate just a functional part of an islet that could be transplanted to individuals that had diabetes, and it could better regulate their insulin. We need to expand the repertoire of different biomaterials that we can use, so you don't have to have a donated trachea, take all the cells away and decellularize it, and then cellularize it with our own patient's own cells. But maybe we could have different types of biomaterials that will help us coax cells to form functional tissue structures. There are lots of legal and regulatory issues. So in regulating the early stages of the tissue-engineered products, what happened was the FDA bins products based upon biologics. So that's something that's coming from you, like blood products are biologics. Drugs, if their intended action is to influence and be metabolized by you. And then everything else is kind of a medical device. So what do you think a tissue-engineered product is? Well, we have cells that are biologic. We sometimes have materials that we're putting these cells on. That's a device. And if we need to put any type of growth factor in it, that's a drug. So everything's sort of a combination product, but we're starting to see more approved products, and so that process is coming along. But I do think we have to be mindful, too, of healthcare costs and reimbursement. I'm excited about all the technical advancements, but sometimes you want to have an impact on people's lives, and that means that you also have to care for widespread adoption, and for this to be used, you have to think about some of the costs of your technologies. And so that's another aspect of the field that we're struggling with, because this becomes almost personalized medicine for each individual person to use your cells. It's not an off-the-shelf product many of the times. So I hope that you found this interesting. I apologize for some of the technical glitches, but I would be delighted to answer questions that you might have.